Hello, everyone. Welcome back to another episode of PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Lotus Maarouf, and today we're unpacking a topic that shows up in clinics, on exams, and honestly, on a lot of anxious Google searches. We're talking about dermatology, but we're focusing on the big foundational patterns: acute dermatosis, chronic dermatosis, and the major disorders of the epidermis you absolutely need to know. I'm joined by my co host and sister, Rand Maarouf, to guide us through this. So, ready, Rand?
Hi Lotus, I'm ready to scratch the surface, pun intended, of skin conditions. We'll be covering the essentials today, from the quick rashes like urticaria and eczema to the long term conditions like psoriasis and lichen planus.
Alrighty, let's set the foundation first. What makes skin conditions acute versus chronic?
It's about the time frame. Acute lesions are the quick visits. They last for days to weeks. They're characterized by inflammatory cells, some edema or swelling and injury to the epidermis, blood vessels, or subcutaneous tissue.
And the chronic long haulers?
They persist for months to years. These long term issues cause permanent structural changes like epidermal atrophy, thinning or hyperplasia, thickening, and even dermal fibrosis or scarring.
Okay, that's clear. Now let's jump right in with a case. Imagine a 30-year-old patient who suddenly develops a widespread rash on their arms and legs, the most unique spots looking like a bullseye target.
That target lesion is the high yield signal for erythema multiforme.
Erythema multiforme?
It's an uncommon self limited disorder that is fundamentally a hypersensitivity reaction. It's your immune system massively overreacting to something.
And what are the main things that trigger this overreaction?
The biggest two culprits are infections and drugs. For infections, the absolute classic is the herpes simplex virus, but also mycoplasma and typhoid. For drugs, watch out for sulfonamides and penicillin, plus barbiturates and salicylates. It can also be associated with cancers like carcinomas or collagen vascular diseases like lupus.
The lesions are called multiforme. What does that mean? And how do we spot that target?
It means many shapes. You see macules, papules, and blisters, but the target is key. It has central necrosis, dead tissue, surrounded by a ring of inflammation. They appear symmetrically, especially on the extremities.
Aha, interesting. Now let's look at the histology. What's the key pattern of inflammation?
We call it interface dermatitis. This is when you see a superficial lymphocytic infiltrate right at the border or interface between the dermis and epidermis. This is the immune attack causing cell death or apoptosis in the basal cells.
And which T cells are the most destructive?
The cytotoxic CD8 positive T cells are the assassins. They are most prominent in the necrotic central part of the lesion, doing the killing.
What about the terrifying widespread forms?
As for those, we have Stevens-Johnson syndrome, which is extensive, febrile, and involves severe erosions on the lips, mouth, eyes, and genitals. The risk is life-threatening sepsis. The worst is TEN, toxic epidermal necrolysis, which causes diffuse necrosis and sloughing of the entire skin and mucosal epithelial surface.
All right, before we move on, a teeny question for the listeners. Which two drug classes are high yield triggers for erythema multiforme?
That would be sulfonamides and penicillin.
Before we move on onto chronic dermatosis, let's hit those other two acute conditions that show up a lot: urticaria and eczema.
Okay, so they're acute but slightly less dramatic than erythema multiforme. Urticaria is just the medical term for hives. It's a very common, quick onset itchy rash that comes and goes.
And eczema?
Eczema is another acute one, generally characterized by redness, itching, and scaling. They're common, they're acute, and I believe they complete our acute list.
Yep. Now we can dive into the chronic long term issues. Our next case is a patient with thick, well defined patches covered in very distinct, loose, silvery scale, mainly on their knees, elbows, and scalp. They also report joint stiffness.
That silvery scaly plaque is the textbook definition of psoriasis. It's a common chronic inflammatory condition.
What defines that plaque?
It's a well demarcated pink to salmon colored plaque with a silver white scale. It commonly affects the elbows, knees, scalp, and the lumbosacral areas.
Okay, got that. What are the two special clinical signs?
The Auspitz sign, minute bleeding points when the scale is removed due to suprapapillary plate thinning, and the Koebner phenomenon. New lesions appear in areas of trauma.
And what is the cause?
It's a powerful T cell driven response linked to the HLA-CW0602 allele. The immune system releases cytokines like interleukin 12, interferon gamma, interleukin 17, and tumor necrosis factor, which signal the skin cells to multiply way too fast.
What about the histology checklist?
We look for parakeratosis and a downward elongation of the ret ridges or acanthosis. We also see suprapapillary plate thinning and neutrophil collections like Monroe microabscesses.
Wait, don't forget the joints.
Oh, yeah, right. Psoriasis is associated with arthritis as well as other systemic issues. Plus, 30% of patients get classic nail changes.
All right, listeners, question time. The bleeding seen in Auspitz sign is caused by which microscopic feature?
It's caused by the suprapapillary plate thinning.
Time for our final two chronic conditions.
Our case for this one is someone with redness and scales that are erythematous, yellow, and greasy around their nose and eyebrows. The greasy one.
So, it loves the oily areas. Is it seborrheic dermatitis?
Yes, that's right. It targets regions with a high density of sebaceous glands: scalp, eyebrows, ears, and nasolabial folds. It's inflammatory, not a primary gland disease.
What are the two major theories for why it happens?
Theory 1, the lipophilic yeast Malassezia furfur. Theory 2, it's linked to increased sebum, supported by its high incidence in Parkinson's disease patients.
Oh, interesting. What about the histology?
Follicular lipping. That's parakeratosis and neutrophils forming a little mound right at the hair follicle opening.
Now, last but not least, our final case is a patient with a very itchy rash of flat-topped purple bumps on the wrists.
And that's lichen planus. There is a famous mnemonic in action. We call them the 6 Ps: pruritic, purple, polygonal, plantar papules, and plaques. It hits the wrists and elbows and shows the Koebner phenomenon.
And in the mouth?
Very common. 70% of cases have them. They look like white net-like areas called Wickham striae. Oh, also an important note. Squamous cell carcinoma has been seen in chronic mucosal lesions.
Microscopically, why is this the ultimate interface dermatitis?
It's the prototypic example. It has a dense continuous infiltrate of lymphocytes at the junction. This attack causes a distinct zigzag contour, the sawtooth appearance. The dead basal cells that drop into the dermis are called colloid or sevat bodies.
And what about the color changes?
It leaves hyperpigmentation called pigmentary incontinence. The pigmented cells are melanophages, not melanocytes. Plus, you see hypergranulosis and hyperkeratosis.
All right, now it's question time. Which term describes the white nut-like lesions seen in the oral mucosa in lichen planus?
That's Wickham striae.
Time for the quick fire recap, hitting every high yield point one last time.
All right, let's lock it in.
Erythema multiforme?
Remember, target lesions, hypersensitivity to herpes simplex or drugs, and histology is interface dermatitis.
Got it. What about psoriasis?
Silver white scale on a salmon-colored black. Also, Auspitz sign and Monroe microabscesses are key.
And seborrheic dermatitis?
That's the greasy yellow scale in sebaceous-rich areas linked to Malassezia furfur.
Lastly, lichen planus?
The 6 Ps and oral Wickham striae. And don't forget the microscopic sawtooth interface dermatitis.
That was excellent, Trent. We covered all the essential acute and chronic dermatoses from a quick case of hives to long-term psoriasis.
Thanks, Lotus. Now our listeners have a solid, bite-sized breakdown of these foundational skin conditions.
Yep. And to all our listeners, thank you for tuning into PodBites. Until next time, stay curious and moisturized. Hello, everyone. Welcome. It's been a long day, bro.
Wait, take a minute. عن جد وشك كتير أحمر.
Hello.
You guys were flawless.